All right, so we have with us Dr. Erasmo de la Peña Maguer from Mexico, going to give a presentation on strain. And we'll also do a live demonstration of our software that will be released this week, actually. We're waiting for all the documents to be signed off, and we will have a strain CT package for research.
Thanks for all of you to join. And Dr. Erasmo, please go ahead. Thanks a lot to show the Q-strain CT for us.
Thank you very much for the invitation. Good evening for everyone in Europe. Good morning for everyone here in America. So I will be talking about research software. That is my only disclosure at this moment. And basically, I will try to answer three very simple questions, which is what is myocardial strain, how it is acquired, and what is it useful for or maybe useful for. So in the next minutes, I will try to answer those three questions. So what's strain? Basically, strain is shortening. And shortening is the magnitude, or can be measured as the magnitude of a deformation, which is a change to its spatial dimension divided by, the change of the length of something, in this case, a fiber, a segment, divided by its original dimension. This is very important to understand because we can have movement. However, that movement doesn't necessarily imply that there is shortening. This is an example in which the strain is changing, or the shortening is changing with movement. And on the lower image, you would to see that there is movement without any shortening. So the strain is 0. What is it that we're looking for in this, when we use this technique? It's basically the displacement of a fiber in a structure in 2 consecutive frames or more consecutive frames, depending on your resolution. We're looking also to the velocity at which this change happens, and the strain, which is the fractional change in the length of a segment, which can be positive or negative. Is basically for longitudinal and circumferential, it's negative, and it's expressed in percentage. So we also looking for the velocity at which it happens and the rate of change expressed in 1 second. There's also something that we can look at, which is the rotation. This is quite important, specifically for certain cases in which we require a proper rotation, such in cases in patients with congestive heart failure. So it is expressed in degrees, and we know already that the base and the apex rotate differently, counterclockwise for the base and clockwise for the apex. And we also look at the torsion, which is the gradient to the rotation expressed as degrees by centimeter. So there are 3 main things that we evaluate, which is global longitudinal strain, the circumferential, and the radial. We also are acquiring new information as to the myocardial twist, also divided by the rate. Now, there is something very important, and it's the fact there is something called feathering. We know that the velocity and displacement are affected by the feathering. This is the cases in which we will get to see normal ejection fractions with already changes in time and in a certain segments, which are not necessarily visible by the human eye. So the strain and the strain rate are not affected by this tethering. So why is this important? We know over time that patients with asymptomatic left ventricular dysfunction, those with chronic coronary artery disease, or patients who have a history of myocardial of congestive heart failure that will be developed over time, specifically the higher the abnormality, which can be asymptomatic, the higher the incidence of congestive heart failure over time. Now, when we look at the pieces that give us the ejection fraction, we have to see that there is a collaboration between the circumferential, the radial and longitudinal strain. Now, when something changes, like in a segment, specifically in a coronary territory, the longitudinal strain might be affected. However, this can be compensated by radial and circumferential strain. And that will give you the same ejection fraction. However, there is something already going on the myocardial segments. Now, what techniques are used? We use currently feature tracking imaging, because this is basically analyzing the change over time, over a period of time, up to dimensional deformation. It uses the standard CTA multi-phase studies, and it is retrofit. But you can go back to a study that was acquired 10 years ago and look at that information, which is very good for research. I'm not going to go into the details of radiation that this implies. However, most of these patients tend to be older, and these patients, not necessarily radiation is a concern for these patients. Now, normal strain, there are not really a large database of normal values. I strongly suggest that everyone in their labs should acquire those normal strains. Patients with intermediate Framingham risk who undergo to the CT that have no risk factor, no coronary calcium, and normal coronary arteries that are reclassified as low risk can be used for this purpose. So this is an example of normal myocardial strain. Now, normal values, we're already working on a small group. We already have somewhere around 55 patients, 60 patients. And what we found is that this is quite similar to what we see in echocardiography. As you all know, strain in echocardiography had the problem of the intervendor variability, which is now less variable. And we will be looking at this over the time that this method is developed with other companies. But currently with Medis, we compare this to CMR, and it's quite correlates properly. Now, this is an example of what we will be looking at. This patient with hypertension, with left ventricular hypertrophy. And we see that already the longitudinal strain is slightly decreased. And this can give you scope as to what the patient might be presenting over the course of time, whether or not this patient is presenting with asymptomatic coronary artery disease or some other type of risk for the fibers functioning properly. So this might be helpful to guide us in therapy. That's something that we need to look at. Now, an abnormal strain, and this is, well, it's quite visible. You get to see the lateral infarct in this patient. However, I'd like to call for your attention on this, on the bullseye, in which we get to see that despite the abnormalities are highlighted here, the normal parts of the left ventricle tend to have a low strain. So this is talking or telling us that this patient might not be having only a single vessel disease. So this is also important. And in the future, with the use of AI, we'll be able to highlight those abnormalities segment by segment. Now, we already know, and thanks to echo and MR, we know that there are certain patterns of abnormal strain that can help us go through our differential diagnosis and help us with getting or connecting the dots. Now, the third question is, what is it useful for? Now, this is basically this will open a new research opportunity to see what specifically CT might be useful for. But we already know that in patients with asymptomatic people, according to MESA, strain is a better predictor of heart failure over time than ejection fraction. Now, we know that when you have a global circumferential strain of less than 16.9, that is a strong predictor of heart failure. And even if you use a single slice, which is the mid slice in a short axis, that still has the same power to predict patients who will be presenting with heart failure over time. Now, something that it's also useful for is patients with post-MI. We know that the mechanical dispersion is the variability of contraction over segments in time. And this has been characterized in patients with long QT syndrome, which we know that the normal mechanical dispersion, which is somewhere around 30 milliseconds, and the patients with long QT, the mechanical dispersion, it can go up to 120 milliseconds. So we know that patients even with preserved LV function, when you have a myocardial strain abnormal, it has an increased risk of the combined all-cause mortality and heart failure admission over time. So just to represent, we did a small study in which we gathered all those patients with a very high coronary calcium score. And we found that those patients, we routinely acquire a coronary calcium score when we do a CTA. So what we found is that the higher the amount of calcium, the lower the longitudinal strain. We still don't know what is the prognosis of this finding. However, we assume that it might give you a better prognostic view or scope as to what these patients need to be treated differently with a higher or a more intensive therapy. Now, one of the places where we know can be very, very useful also is the lead placement for CRT therapy or cardiac resynchronization therapy, in which we already know that we need the CT for the mapping of the veins. Now, when we see those patients who respond, we know that on the left side, immediately after CRT, the peak LV twist that can be measured with this technique increases, and over time it changes. However, those patients right after the lead placement, they have a decreased peak LV twist. We know that over time, the 6 months follow-up, there will be no improvement at all. So another area where we can use strain as a helpful tool to give us more information is on the differentiation of restrictive versus constrictive, which we all know that is always problematic to sort out. Now, on restrictive, basically torsion, it's preserved as to constrictive, where the torsion is decreased. So that's one of the points. And also the longitudinal strength for restrictive is decreased as compared to constrictive pericarditis. And another area of interest is also the atrial strain. We can look at the atrial strain and calculate the EF of the atrium and measure the volumes, but also the longitudinal strain of the atrial can give us some prognostic information. There's a very nice study by Duco in 2015 in which they show that when using the CHA2DS2-VASc score and when they included the strain of the atrium, they had a better probability of predicting which patients will have a stroke. So we know that there's a higher volume, but it's also decreased strain in patients with a higher incidence of stroke. That's probably telling us that there is a higher degree of fibrosis in that atrium, and the strain rate is also abnormal. Now, the right ventricular longitudinal strain is also very easily visualized with this technique, and it might be helpful in those cases. For example, this is an example of a case with a triple rule out, in which the patient had a massive PE, in which we can visually demonstrate, we can see and measure quantitatively the strain to which that ventricle is having, which is a very abnormal strain with a decreased ejection fraction. There you get to see that the apical right ventricular wall is preserved, which is a McConnell signs, and there's the abnormality on the RV free wall with a very low global longitudinal strain, which is a prognostic factor. Now, we know, and this is already been shown by a lot of studies, which adding global longitudinal strain to our clinical or routinely analysis of patients, we know that it'll increase the scope as to the prognosis and sensitivity and specificity, specifically for as compared to exercise ECG and patients with viability. There is so many papers that are looking at the value of a strain using CMR currently, and we look forward to see what we can add to coronary CT with this technique. Now, so we conclude that the feature tracking strain is able to detect subclinical disease, and it's very good, and it adds value to the left ventricular function evaluation. It has a prognostic value, it might be helpful as a therapeutic follow-up tool, and it adds important information to what you already have. So this can help you guide your patient through diagnosis and therapy. Well, that's basically it. Thank you very much.
Thank you very much, Erasmo, for a nice presentation. In the meantime, we have a question that came in.
Yes, actually already before. So in the beginning, he wanted to know if you're using SYN images for the CTA. He is asking, do you need a separate CT acquisition, or those images can be reconstructed by using original coronary CTA scan?
Yeah, they can be reconstructed using your multiphasic information. We try to use 100 kbs to decrease the radiation, and we acquired the whole cardiac cycle using also radiation modulation. So our base study, it's somewhere around 2.5 to 3.5 millisieverts. It's not that bad as to compared to what we used to do 10 years ago, which were 15, 16 millisieverts. And if you compare it to a thallium scan, that's 32 millisieverts or 5 millisieverts over coronary cath or angiography. Answering the question, if you acquired the multiphasic study, then you're good to go. You can just go back, grab that information that might be stored in your packs, and then you just reconstruct it the way David's going to be showing us how to. So an important point, you can do, what we found is that you can do the base, mid, and apical LV sinus using a 5% increment or a 10% increment. We prefer to use 5%. So, and then you can do that on your workstation and send them to the Medis analysis software. Or the only problem is that you will be losing the temporal information. And so we prefer to do it on Medis, like Davis will be showing us.
Yeah, I have here, thanks. I have here 3 cases. I think I'm going to show this case that you also showed in the presentation, was a lateral infarct, showing the workflow, how you can actually obtain strain values. There's basically 3 steps that are involved. The first step is to create reconstructions, and you have to make sure that you have temporal resolution information in there. So I have here this this scan. There's 19 time points, 0 to, or actually, you can reconstruct how you want it. And there's a trigger delay over here. That means that there's temporal resolution information in there. If it's not, then it's possible to add it when you're going to reconstruct. So I'm going to show you here how we're going to use our 3D viewer. This is still using a prototype that we will release this week, the final version, but it should work quite well. And here we can see that the data is loaded in our 3D viewer. And from here you can, basically, if you want to do a 4-chamber, for instance, you can just use this multiplanar reformatting tool to align, to orientate the image in the right way. But that's quite basic 3D post-processing. So here I should have something that resembles a four chamber. And then to create a reconstruction, I can click here on Create Reformat in the right upper corner, and then I click in the viewport where I want to create the reformat. So I'm going to change a little bit the size so that I have the whole ventricle in there. If you would be interested in the atrium, you could make it a little bit larger. And then you can name it something. And make sure that your projection method is on average intensity, because if you're going to do it on the maximum intensity or minimum intensity, you will be under overestimating volume. So average intensity is what you want, and you can pick a slide thickness and some settings. And then very important is to keep either the temporal resolution or that you can enter it as your scanner is acquiring it. So for probably Toshiba and Philips, you will probably need to enter it. And then once you have done that, you can just finish this reformat and right click, and you can send it to Medis Suite. And this is the way you can create reformats, either long axis or short axis, doesn't really matter. I've prepared a few. I'm going to close this. If it's a very large data set, sometimes it can be even more than 2,000 images. It could even be 8,000 images. So it might be good to do these reformats, and then just loading the reformats. I can also load the short axis that I did previously. We can load into the Medis Suite workflow and then continue from there. So let's say we would like to do a longitudinal strain analysis. I'm going to select 3 slices and load them into QMass. And that's where we're going to do the next step, and that's getting the points in place, like the contours in place. And it is a manual effort at the moment. We will be looking into more automation in the future, but for now it's just using some tools. It's pretty straightforward to get contours in the end diastolic and systolic phases. And let me just show you how this can be done. I can do this for the 2, 3, and the 4 chamber. I'm just going to control that. Something like this. All right. And then you can always modify the contours using the right mouse button to rubber band them. And the final one, this is the 2 chamber. And we go to the ancestry. All right, so this is basically some manual step that you need to carry out. And then once that's done, I click on this button for launching QStrain. And that's where features will be tracked so we can get time curves. Now, first of all, here's a green dot indicating that there's a contour available. And all you need to do is just load it into the viewport. Those who are very familiar with the MR strain package that we have will already know what to do here. It's pretty straightforward. So now it's calculating the feature tracking, and in a couple seconds we'll have results here on the screen. So now here you have the 2 chamber tracking the features. You might want to change the window width, window level a little bit, something we sometimes need to optimize a bit for CT, or when there's artifacts because of wires, it could be useful. And here I can show you a nice 3D movie. So in the middle, we already have global longitudinal strain results, global circumferential strain. We also calculated radial strain based on the long axis with an asterisk, because actually you want to quantify that probably with an epicardial contour as well. I just did an endocontour. Now, one of the most important things here is to make sure that your end diastolic and systolic phases are correctly placed. It doesn't have to be that way. So you can still move them. For instance, if I would move it here, I would put it in the incorrect place, and then you'll see that the longitudinal strain is around 5.5%. If I put it here at the smallest volume, I get about 12%, which makes a lot of sense. We have regional results. It's very important to check the orientation. Sometimes, let's say, for instance, here a 4-chamber, and I would go to regional results that I can take a look at. Sometimes the image is not correctly placed, and you would need to flip results. So here I have the basal infraseptal wall. That makes sense. You have to check that. Sometimes it doesn't do that, and then with the button on the right, you can mirror this image, and then you can also change the naming conventions. I think we have some more questions coming in.
Yes. Can this software process CTA for all major vendors like GE, Philips, and Siemens?
Yes. So we have been running tests, and we see that we did specifically for this release some changes so that Toshiba and Philips data can be handled better, including making sure they're grouped correctly, and also getting the timing information in there if it's not already there in the DICOM header. So you are allowed. So that's very important. And we have seen that the tracking quality is in the vast majority of the cases that we are looking at pretty reasonable. Even if you go to older 64-slide CT scanners where they only have 10 time points with GE, we have some cases looks good. So we are very vendor independent. Any more questions?
What's the major difference between Q-strain CT and Q-strain MR?
Basically that there's not a lot of difference, except that the one is for CT, that the tracking is optimized for CT, and the other one for MRI. So apart from that, the workflow is pretty much the same. If I go here to regional results, I can also show you get different parameters like strain or strain rates, displacement. I think in general the temporal resolution in MR typically is a bit higher than in CT. So that is a good thing for strain, of course, while the spatial resolution in the CT is a little bit higher than in MR. So that it depends also a little bit on the scanner, what it is. Some vendors have, I think the highest that I know of is about 70 milliseconds or 68 milliseconds that you can get on the CT scanner in temporal resolution. But yeah, the software basically is the same. Now I can show you another example of a short axis strain. I have here also a reformat that I prepared of the same heart. Let me show you. I will load it into QMAS, and I'll do three. I will just trace 3 contours just to save some time. Let me see. For instance, you can start here in top slice where you don't have the outflow tract. So it might be this slice number 14, where I can try to get the contours in place. This is a single click, and then maybe I put 3 slices. So I only do the endo here. You can draw the epi as well, and then you'll get let me go one more down to have a gap of 3 slices. Let me just get rid of these. Something like that, and then another 3. Yeah, should be more or less okay. Okay. Now, if you load this into QStrain, we'll do some short axis. And I load the 3 slices. All right, so now we have a little bit the window level that can be a bit improved. So I'm doing that here. This looks a lot better. And what you see here is also the rotation that we get. So in this graph, we see the rotation, which is like this. Maybe we want to move the end systole a little bit further, get a bit more accurate results. like this. So per slice, you can see this. You can see this rotation. And also we measure the delta rotation, which is the rotation between the top and the bottom slice. Now let me try to do one slice. And if I do one slice, I will show the radial strain as well. If I put an epicardial contour, it will take a little bit more processing time. So let me just do it in one slice to get it okay. And it's a little bit tricky because, of course, you need also good contrast. And if you have less contrast, if there's no difference between the right ventricle and the myocardium, it's a bit more challenging. But still, it's possible to measure. Just showing you. Okay, and this is the top slice. So we did the middle slice. We did the endo and the epi contour. All right, so now we just have one slice, and here I can show you the contours. Now, in this case, it's very challenging because there's not a good contrast. But in the case there's a better contrast, then it will work a lot better, getting these contours over time in place. Although, as you trace the end diastole and end systole manually, the value that you get for the radial strain should be more or less okay, because it's not being tracked, it was manually placed. So that's always good for the results. But in this case, the tracking quality is very challenging for the epicardial contour. All right. Don't know if there's any more questions. Otherwise, I think we reached our time for this webinar. So thanks a lot for your for joining. And then I think just want to show one more thing.
Yeah, so thanks all indeed for watching, for joining us. We will send you the recording afterwards. If you want to get a live demonstration from one of us, we are present at the RSNA and at the EuroEcho, so you can always come there to have a bit more talk about this. If you have any questions afterwards, no worries. You can also send this to sales@medis.nl, and then your answers will be given as well. Have a good day to all of you,
Yeah.
and hopefully till next time.